Good afternoon, everybody, or good morning, depending on where you are in the world, and welcome to this IPC Partners Journal Club, which we're delighted to partner with Molnlycke. And today, Jon is going to be talking us through our paper. And Jon is here to talk about risk factors for post-operative Staphylococcus aureus infection. And Jon and I feel like we've got Staph aureus on the brain at the moment. We talked about Staph aureus in one of our last journal clubs with the Healthcare Infection Society, looking at MRSA. And so here we are talking about it again. Jon is going to talk about this paper, which is the association of Staph aureus bacterial load and colonization sites with the risk of post-operative Staph aureus infection, which was published quite recently in 2024. So Jon and I are both at conferences today, and we just were talking about our days, and we're just saying about how it's nice to give a little update about what's going on. So I'm at the Healthcare Infection Society annual conference in central London. Been some great talks. Just heard Alex Sunderman talk about the use of genomic surveillance for IPC and interventions and outbreak infection detection and prevention. Jon, I don't know if you want to talk a little bit about where you are.
Yeah, hi Phil. Hi everyone. Thank you for joining us as ever. I'm at a vascular access conference today. Always feel slightly out of my depth at vascular access conferences because whilst a vascular access team does fall under me in terms of the kind of direction of the service, I don't insert lines. But it's been a fascinating day and so much potential for improvement. So for example, two areas have come out really strongly. One is huge opportunities for patient engagement in vascular access and improvement in care. Almost 70% of patients have some kind of vascular access device, so it's almost ubiquitous. And the other thing is improved surveillance. We have so limited data around complications around vascular access devices. Anyway, we're going off track.
I was about to go into what else I've learned from the HIS conference as well. But yeah, if you go to the next slide first, Jon. Just before I pass over to Jon, I'll just give you an overview of those of you who are maybe new to the IPC Journal Club. So IPC Partners are running a journal club every 2 weeks, and these are just some of our aims. We don't take ourselves too seriously, but we like to provide an insight into a topical IPC published paper. Really, and this is a plea, that the whole purpose is to generate discussion around this topical IPC published paper. So please use the chat to share your experience, or you can use the question and answer box if you'd like to ask questions for Jon about the paper or our own experience of MRSA or Staph aureus and its management. We like to think that we're building confidence for other people to talk about journal clubs and papers and their own experiences of research. We'd like to think we're building a bit of a network of enthusiasts. And again, Jon and I don't take ourselves too seriously, so we like to have a bit of fun as well. Just the final bit of housekeeping. All our journal clubs are recorded and they're made available online via the IPC Partners YouTube channel. So this session is recorded. And just a final reminder, please use the chat and the Q&A for your questions for Jon. So Jon, it's over to you.
Okay, thanks, Phil. Last week, I think it was only last week, we were here with the Healthcare Infection Society 7 days ago. It feels like a long time. We started that session by thinking about the last time we actually saw the lovely bunch of grapes, Staph aureus under the microscope. I'd actually planned to pop into the lab and actually look down the microscope so I could ask you again and embarrass you, but I haven't. So the answer is still many years ago for me.
Yeah. Same for me.
Yeah. So I'm in good company. Okay. So let's think about Staph aureus and SSI. I did a PhD on Staph aureus many years ago, and so have some history with the organism. It's a really fascinating organism. We know that the nose and parts of the nose provide the natural niche for this organism to live, and that comes out strongly in the findings of this paper. This paper is important because Staph aureus causes around 30% of all surgical site infections, and surgical site infections can affect up to 20% of surgical procedures. Now that depends a lot on the category. If we were talking about elective orthopedic procedures, it would be less than 2%, hopefully much less than 2%, whereas some more complicated gastrointestinal procedures have a much higher rate of SSI. The setting in which the surgery is undertaken is important too, both environmentally and the scenario as well. So we know that emergency procedures or Follow-up procedures following an initial procedure have a much higher rate of SSI than a single procedure that is planned. Each surgical site infection has huge impact both on the individual patient and on the organization and on society. It influences the patient experience and the patient journey. It often extends their inpatient stay. It drives antimicrobial usage and has financial costs. Now, we could have a whole session on talking about the financial cost of SSI, but a conservative estimate is probably around £15,000 per SSI on average. There's also a measurable carbon impact for each SSI. So if we can prevent SSIs, we are contributing to a more sustainable delivery of healthcare. We already know, it's quite well established in the literature, that colonization with Staph aureus is a really important risk factor for SSI. But the reason I like this study so much is that it explores this association of Staph aureus with SSI in more detail, in that it looks at whether there's a role for the bacterial load, so how much Staph aureus is there measurable in the nose, and whether colonization at other body sites, either in conjunction with or independent from colonization of the nose, is an independent risk factor for surgical site infection. So before we go on to the details of the paper itself, I just want to put this paper before you. It's quite an old one now, something like 13 years old. It's a piece of qualitative research that was published in the Journal of Infection Prevention. If you haven't read it, I would recommend you go and give it a read. It's an article that has stuck with me because some of the things that you read in it, you can't unread. And I mean that in terms of their emotional impact, but that's in a good way as well, because it reminds us of the human cost and the impact of surgical site infections, so many of which are preventable. You can read, as I'm talking, that the impact that the SSI had on this one patient from their experience, but there were other experiences that came across really strongly. One thing that resonated particularly with me was the smell of surgical site infections and how difficult that is to manage in a non-hospital setting. That you feel like this surgical site infection is an extension of you that you'd rather, to say the least, not have. So as well as the financial and the operation and the clinical impact of SSI, there's a significant impact on patient experience. Okay, so back to the study. This is a really big and impressive prospective observational cohort study published in Clinical Infectious in Open Forum of Infectious Diseases. They used a data set from a big Aspire SSI study, which was a really big study looking at the association between Staph aureus colonization and SSI. So to be enrolled in this study, there were around about 11,000 patients enrolled, and they were followed up for 90 days after surgery to evaluate SSI and BSI caused by Staph aureus linked to that surgical episode. So for this study today, patients were selected from this Aspire study in a ratio of 2:1 from carriers to non-carriers. If anybody read the blog I wrote yesterday, I need to correct that because one of the study authors has been in touch with me, and thank you so much for getting in touch, just to correct a slight misunderstanding I had of the study design. So this is a correction from that blog from yesterday. Okay, so moving on to the results then, this is the proportion of sites colonized for the patients who were colonized at any site with Staph aureus. So almost half of the patients were colonized in the nose only, around 20% in the nose and throat only, around 14% in the throat only, and then the other individual groups are account for the other colonized patients. A total of 100 Staph aureus SSIs or BSIs were identified during the study. 86% 86 of those, which is in fact 86% because it's of 100, were in colonized patients. So this is a table from the study, and it's a multivariable weighted analysis. So they selected the colonized patients from a wider population in a 2-to-1 ratio, but they did some clever adjustments in the statistical methods to mean that these odds ratios are applicable to the non-selected population. So in the selected population, the proportion of colonized patients was 67% because they were selected on a 2-to-1 basis. In the population they selected them from, it was, as you'd expect to see, about 30%. So all of these hazard ratios that you see in the tables are corrected for that difference in the original population and the selected population. So the key findings are that both the Staph aureus colonization rate at any site was associated with Staph aureus SSI or BSI, and the adjusted hazard ratio was 4.5. So patients with colonization were roughly 4.5 times more likely to develop a Staph aureus SSI or BSI than those who were not colonized. Interestingly, though, when they looked at colonization, which was extranasal, so colonization at any site that did not include colonization of the nose, this was not associated with Staph aureus SSI or BSI. Now, that being said, there is a slight caveat to that, in that the number of body sites that were colonized did increase the risk of SSI. So let's just have a look at that association there in a little more detail. So this is looking at any body site colonization. So it could include the nose, might include the nose, might not. Carriage at 1 body site, carriage at 2 body sites, carriage at 3 body sites. You can see the adjusted hazard ratio is increasing stepwise for each of those categories. So the more body sites that were colonized, the higher the risk of SSI, to the extent that if you had carriage at 3 or more body sites, you were 8.5 times more likely to develop an SSI than if you were not colonized at any site. The last main finding of the study was an association between the bacterial load in the nose, which was measured semi-quantitatively in the lab, and the risk of Staph aureus SSI or BSI. And similar to the association between the number of body sites colonized, the study found that the bacterial load was significantly associated with the risk of SSI or BSI in a stepwise manner, to the extent that by the time you got to the 4+ measurement from the semi-quantitative test in the lab, you were around about 3.5 times more likely to have a Staph aureus SSI or BSI compared with non-colonized patients. Oh, sorry, compared with patients who are not colonized in the nose but colonized extranasally. That's the reference they used for this. So I tried to put this graphic together just to visualize this and help me to synthesize these findings. They found an association between the number of, that's quite confusing, NO there doesn't mean no as in 0, it means short for number of body sites colonized. They found an association between the number of body sites colonized and the risk of SSI. They also found an independent association between the bacterial load in the nose and the risk of SSI or BSI. So how do these variables relate to one another? Is it that if you have a higher bacterial load in your nose, you are more likely to have a higher number of body sites colonized, and therefore you have an increased SSI BSI risk? So that would point back to the bacterial load in the nose being the main driver of the risk. Or is it really true that independently of the number of the bacterial load in the nose, if you have more than one body site colonized, you're more likely to develop SSI or BSI? The answer is we don't know. This study was not configured to help us to fully answer that question. However, this is my hunch. If I was to guess which came first, the chicken or the egg, perhaps I would suggest that the egg came first. But equally, if I was to suggest which is the most important driver here, I think that the bacterial load in the nose is most likely to be the key driver that drives the increase in body site colonization, which then results in an increase in the SSI and BSI risk. But that's an interesting point, and I think it would be worth discussing that. So moving on then to strengths and limitations. The study is based on a huge, gargantuan data set, including more than 5,000 patients who were colonized from 33 countries 33 hospitals in 10 European countries. The data was collected some time ago now, 2016 to 2019, not ages ago. It's already 5 years old, so that may be a slight limiting factor. Patients who were colonized with Staph aureus were more likely to have received preoperative decolonization. That's one of the things that came out as one of the minor findings. Despite this, the association with the increased risk of SSI due to Staph aureus remained. So you may have expected that increased chance of having decolonization to reduce the risk of SSI. So it may be that if that additional association with decolonization hadn't been there, the associated risk may be even higher with Staph aureus colonization. The study included a focus on clean and elective procedures. We know that a big proportion of surgery doesn't meet these categories and has an even higher rate of SSI. So it would be interesting to see whether these associations held out for the wider group of surgical procedures. From a lab point of view, the bacterial load was assessed semi-quantitatively in the lab. This was due to a streaking method where you do several different streaks from the initial inoculation. I'm doing it with my hands, you can't really see it. So there's an element of subjectivity around the interpretation of that, which may have influenced outcomes slightly, although probably not very much. Also from a lab point of view, it didn't look like they required confirmatory test for Staph aureus beyond colony morphology on a chromogenic agar. So it may well be that Staph aureus prevalence was slightly overcalled in the study. Patients were followed up for 90 days after their surgery, which is reasonable for SSI. It's possible that some of the BSIs captured related to some other causes that occurred during that 90-day window. Difficult to know how much of an influence that may have had on the study. Again, probably not very much. So, points for discussion. Extranasal carriage was not associated with Staph aureus, SSI or BSI in this big study with solid statistical methods. Does that mean that extranasal colonization in the absence of nasal colonization isn't significant as a factor for Staph aureus? Perhaps that is true, and that's what the study does suggest. There was association between the bacterial load in those and the risk of SSI. So does that mean that we should be targeting patients with a higher bacterial load for specific interventions? In terms of policy, not many centres would screen patients for Staph aureus prior to surgery. Many would for MRSA for some procedures. But why don't we do that? Why don't we screen and treat for Staph aureus in the way that we do for MRSA for some procedures? Is this something we should look at again in the light of the findings of this study? And finally, what implications does this have for our approach to decolonization or suppression strategies prior to surgery, be that mupirocin or chlorhexidine or other approaches like nasal photodisinfection? And finally, before we get to some questions and discussion, what does this mean for IPC? Well, my interpretation of this study is that all roads point to nasal colonization with Staph aureus as the key driver for the risk of Staph aureus SSI or BSI. I think it's time to consider and reconsider again a screen and treat approach to prevent Staph aureus SSI or BSI, at least in some surgical categories, or perhaps a universal decolonization approach if we don't like the idea of screen and treat. And we should all take the opportunity to look carefully at our Staph aureus decolonization approach. So Phil, I'm going to stop and let's see what's happening with the questions.
Thanks a lot, John. I really enjoyed that. So please use the Q&A for any questions you have for John or for me about the study, and also the chat if you'd like to share any of your own experiences around SSI and BSI and Staph aureus colonization. I've got loads of questions, John. I'm still trying to kind of, map out in my own head how this nasal colonization then leads into colonization for the rest of the body. And I think you explained quite a complicated sequence of events really well. But what do you think it is about nasal colonization of Staph aureus that leads to, why is that the primary site for colonization in other body sites, do you think? What is it about the nose?
So I think the answer to part of that is a bit of an unknown. Why does Staph aureus colonize the nose versus other body sites, and why do other organisms colonize different body sites? I think there's still some significant unknowns to answer that sort of fundamental question. It's to do with where the organism has come from, the ecological niche it has, the tools it has to survive, and the way that it adheres to human tissues. But in terms of more pragmatically, what's the relationship between nasal colonization and other body sites? How does the Staph aureus get from its primary niche, which is the nose, to other body sites? I think it's this.
Okay.
If you look at the data, when you stick a camera on somebody and watch them unobserved, then we touch our noses a phenomenal amount. I can't actually remember the number of times. I'll have a look when you're kind of looking at the next question and come back to you. But we touch our nose all the time and we don't even think about it. And then we touch other body sites, and that kind of seeds colonization at those other body sites.
Yeah, I think your reference to us touching our nose and our faces reminds me of a great talk that Martin Keenan always gives, just about that transmission route, and I think it's in the region of 20 times. And then he's got this wonderful picture of the late Queen picking her nose, and just saying that everybody does it, so everybody comes into contact with their nose and then spreads it that way. Okay, that's really interesting.
Phil, I've got it. So the average adult picks their nose about 4 times a day.
Okay.
And the average adult touches their eyes, mouth, nose, or chin a staggering 20 times per hour.
So I was right.
You were right. Yeah, you got it.
Yeah.
But 20 times per hour, that's a lot.
Yeah. I mean, when I read that stat, I think, do I actually do it? And then I go to touch my face straight away.
We've probably been observed touching our hands on our face during this call.
Yeah, I mean, you just touched it 10 times in a second.
Oh, well, come on. I was showing you that. You can't count that.
No, I know. Okay, the Q&A is starting. We know it's always people are reluctant, and Emma is great, put a great question in. So please continue with the Q&A. But Emma asks, John, I'm currently suffering from a superficial SSI post-op orthopedic surgery. One of the key issues is surveillance, in brackets, and reporting, and also the empirical treatment leading to culture negative reports on sampling. Should we be looking at changes in these areas? That's a great question.
Yeah, well, firstly, Emma, thanks for joining while you're recuperating from a superficial SSI. I hope it's not too serious. I agree with you completely on both of those main points. So the post-discharge surveillance network that we have for most of our procedures is pretty poor. And we know that if we don't do post-discharge surveillance, particularly in some surgical categories, but really in all surgical categories, we're only looking at the tip of the iceberg that's floating above the water, and the huge pyramid underneath it is under the waterline. It's not seen by our organization, it's not managed by our clinical teams, and that has implications both for us and the healthcare system, because I think it's true that many of the SSIs that present post-discharge, an acute provider would really want to know about and would want to take care of, would want to readmit, but often that doesn't happen. They go to general practice, they go to their GP, who maybe doesn't understand their history, and perhaps they don't get the best level of care, and maybe are a bit slow to be readmitted when they should be, because of the SSI. The other part of it is related to that. By the time you get to a point in your healthcare journey, if you have an SSI post-discharge, oftentimes you're already started on antibiotics, and that can result in a culture negative screen that can then confound the decision making about whether it's an SSI and how it should be managed.
Great answer, John. I think the whole follow-up post-surgery is really interesting, isn't it? And you know, this idea of following people up 30 days post-surgery when they've probably already developed the SSI if they've got one, and do we need to be using more AI and smartphone technology to be able to kind of report back to healthcare providers to track wounds and treat them more effectively is really interesting, isn't it? Okay, loads of questions coming in, John. So Catherine asks, I found this association fascinating. Do we just opt for blanket nasal decolonization pre-op? And how do we balance that against mupirocin resistance?
Yeah, I think it's tricky, isn't it? I suppose this comes slightly back to the age-old tension between the best interests of the patient and the best interest of the group of patients or society. It would be in the immediate best interest of all patients for everybody to get some prophylaxis, both topical and systemic, prior to all types of surgery. We know that that would significantly reduce the risk of SSI, but that would massively increase our use of antibiotics, both topical and systemic, and that's an unacceptable risk burden to say all patients receive, you know, the maximum surgical prophylaxis. So how do we do it? We do what we currently do, which is to categorize the risk based on the procedure and the patient, and have quite a nuanced approach to systemic prophylactic antibiotic prescription. So I don't think we should go down the route of universal mupirocin, even in categories where we have a high risk of staphylococcal SSI infection. I think that results in potential for significant increase in antibiotic resistance. I think there's some different approaches to nasal photodisinfection that we could look at. There's nasal photodisinfection. There's also some chemical-based approaches that don't require antibiotics for disinfection of the nose. That we could look at as alternative strategies that may be a better balance between reducing the clinical risk of poor outcome and the risk of future resistance.
Yeah, it's a really important point, isn't it, about getting that balance right between risk and then AMR. But yeah, I agree with you about that with regards to mupirocin.
Phil, before we go on to the next question, can I just ask you, what do you think about the idea of screen and treat for Staph aureus? Because there's some really good data that for all surgical categories, if you screen and treat for elective surgery, it reduces the risk of poor outcome if you treat the colonized individuals. But it's just not a concept that's really taken on. Why do you think that is?
Personally, I probably think it's down to just being able to get the compliance right, and ensuring that you can screen everybody that you need to screen. I mean, it's a big undertaking, isn't it? And there are all kinds of challenges about how you make sure you get that as compliant as possible. I think I do see the benefits, like you kind of just alluded to, but it's just making sure that you can make that work in your systems approach and ensure that you can then, there's one thing to do the screening, but then how do you ensure the compliance with the treatment as well? So I think there's two avenues to it. Okay, I think there's a question and a comment here from Tom. Tom says, thank you, timely. Gerft about to recommend 24-hour skin decolonization prior to all major surgery, but not recommended nasal treatment as part of this at the moment. I also think we need to sort out our surveillance. So much we should now do with our expensive EHRs. I don't know if you want to comment on that, John.
Oh, there's loads I'd like to comment on that. Thanks, Tom. Good comments and questions. So where to start? I mean, having looked at some patient journeys through surgical procedures at several different large centres in London and to an extent elsewhere, I'd be happy if a patient just had a wash, a proper clean, without, you know, chlorhexidine or anything before their surgery. Even that, I think, would improve things, because very often patients don't even have proper skin hygiene. because they're not in a position to do it themselves, and we often don't have the facilities to do it ourselves. So I think there's some really, really basic fundamentals of care to sort out here that need to happen. And that doesn't mean we shouldn't consider new approaches and adopting innovation, but at the same time, we need to have a really, really clear eye on the basics with SSI prevention here. Otherwise, we're not going to get the return on investment of the other approaches we might consider. And then surveillance, it's still true that many healthcare centres, even big and well-resourced centres, have no clue of their SSI rates across the surgical categories. I remember when I joined the NHS, actually 10 years ago now, one of the first questions I asked was, well, what are your rates of SSI across the various categories? Don't know. We could have had raging SSI rates in certain categories and just not known about it. So I think surveillance post-discharge is crucial, but even proper and accurate surveillance of in-hospital SSI rates needs to be standardized and delivered across organizations. And that way we can then measure the risk, justify to the organization the need for investment, and also measure the impact of interventions. And I agree with Tom that electronic patient records offer the potential to do this, but it still requires some pretty hard graft in terms of configuration.
Yeah, I think you make a really good point there about leveling the playing field in terms of surveillance, and then we can make sure that these interventions are effective, and then we can be, monitoring our infection rates more accurately and frequently. There's some comments I'm going to read here, John, and then I'm going to go back to the Q&A. Holly, nice to see you. Holly says, as an action from SSI surveillance, we now screen and treat patients for MSSA, having overnight stay, orthopedic surgery or breast surgery. That's really interesting.
Okay, so there's one centre that has adopted a screen and treat approach. That's really interesting. It'd be good to know actually through a poll how many centres do screen and treat for S aureus.
Definitely, but a very interesting point. Donna says we're seeing more MSSA SSIs than ever. That's a bit of a tongue twister. And yet we don't diagnostically screen nor treat pre-op. It's an interesting dilemma for managing onward associated SSIs. I very much agree with body wash, which is implemented more universally, and pre-op for higher risk procedures. Good comments. Okay, back to the Q&A. We've got another one here, John, from Samantha. This is a great question. Should we be thinking about suppression therapy continuing post-op?
Yes, I think we should. I think it would be a wise thing to do. We've got to have an eye on skin health. So if by suppression therapy we mean chlorhexidine body washing, that does have some unintended consequences in that it can dry the skin and leave you prone to other skin related conditions. So I don't think I'd want every patient on chlorhexidine bathing forever. If we're talking about nasal decolonization, again, we're back into the territory of antibiotic resistance and that balance between outcomes and future resistance. So some level of suppression therapy is an interesting idea, but again, it might have to be along the lines of that nuanced recommendation, in line with surgical prophylaxis, to say it's high risk patient groups in certain areas of the hospital, perhaps, but it's definitely something to consider.
As another comment from Sam saying we screen and treat for MSSA in cardiac and orthopedics for electives, which is a really relevant point. John, there's another question in the Q&A, but before we come to that, I just wanted to ask your opinion. So, we talk about mupirocin being universally recognized as the port of call for nasal decolonization, and you touched upon some of the other alternative methods. Where do you think the evidence needs to go for us to potentially investigate some of those alternatives like photodisinfection?
Well, I think the imperative is that we need to. So it's almost incumbent upon us to justify why we're taking an antibiotic approach, when I think there are some other approaches that already have some evidence. So I'm very open to looking at alternative approaches, especially to mupirocin for nasal disinfection.
Good point. Okay. Another comment here from Lisa, just a comment about pre-surgery screening, which we do for some procedures. One of the issues is that once we screen and we know someone is colonized with something, we can't unsee that. And then for all the patients' follow-up appointments, they're on the additional precautions or need clearance screens. The outpatient follow-up clinics find it difficult to accommodate patients on precautions or clearance screens and really push back on this. So I have a really hard time getting clinics to agree screening. I mean, that's really interesting, isn't it? And kind of taps into maybe the human behaviors side of this.
Okay, so I think there's two parts of this question that could be interpreted in two quite different ways. If we're talking about a program of pre-surgery screening for MSSA, i.e. just good old regular Staph aureus, and the prospect that that might influence the future care pathway, then that would be a really, really unintended consequence, because we know that Staph aureus colonization is incredibly common. 1 in 3 of us are colonized all the time. Even more of us are colonized part of the time. So everybody in the hospital, well, not everybody, a third of patients in the hospital would be on this kind of higher risk pathway if we're considering MSSA colonization as something that should influence patient care. So that would be a real unintended consequence we'd need to educate away from. If we're talking about colonization with, let's say, MRSA or CPE, which does genuinely, and I think rightly, affect the patient journey through the hospital, and we'd need to apply contact precautions until clearance screens have been completed, etc., then I still think there's education work to do there, because even now patients with MRSA or CPE colonization are treated as if they're the untouchable and put on the end of surgical lists, and patients on the end of surgical lists we know are the first to be cancelled, because if surgery overruns, it's always the patients on the end of the list that will be cancelled. My own view is we need to move away from that kind of end of the surgical list approach for managing patients with infection risks, but rather integrate the safe management of patients with infection risks into our normal surgical flows.
Yeah. I couldn't agree more about that safe management within our kind of routine patient flows. I want to go a little bit left field, John. I think it was one of your first slides, you talk about the impact of SSIs on carbon footprint. There's obviously a huge focus on the sustainability challenges facing healthcare providers all over the world. Has anybody, to your knowledge, done any kind of studies showing about the impact if you can reduce SSIs, what that means in terms of carbon footprint impact?
Yeah. So one of my colleagues, Melissa Rochon, and I did a piece of work. We were looking at post-discharge surveillance and the impact of that, and some electronic systems. But we did measure the carbon footprint of the surgical SSIs in the study that we did, and the carbon impact, we measured it to be between 5 and around 2,500 kilograms of carbon dioxide per SSI, which is a big range. And I think it's probably, it all goes back to extended inpatient stay. Probably that's where you're likely to see the most impact, both financially and environmentally, from an SSI. And it also depends what we capture in the measurement as well. Are we talking about sort of whole economic cost, including time off work and those kinds of things? Or is our focus from a provider point of view very much on the acute healthcare setting? But that was a very small piece of the work. I think there's a lot more work to do looking at the sustainability impact of reducing SSIs.
Great answer. I remember seeing a very poignant video that Graham Pike shared in one of his sustainability talks, and a patient had basically just mapped out all of the different consumables and PPE that had been responsible for being involved in her care post developing an infection in hospital. And when you saw it all laid out on the ground, you know, the gloves, the drapes, the gowns, the aprons, etc., it was truly staggering. So yeah, you know, that range you talked about, what does that mean? Because, you know, I should know more about what a kilogram of CO2 looks like, but do you know what that means in terms of miles driven or kilometers driven or anything like that?
Yeah, now you're asking. That's how it's normally done, isn't it? I can't do that
No.
off the top of my head, unfortunately.
Yeah, it's just helpful, isn't it, to try and put it in a bit of context and contextualize it. Oh, Tom says screening is very carbon intensive, so that's interesting. Does it pay back the dividends, I guess, is a big question. Good comment, Tom. I had a final question, John. Right, I've remembered it. So unless there's no more in the Q&A, we'll close after this one. But where do you think the future for Staph aureus decolonization lies, John? Do you think there needs to be a change in our approach? What are your thoughts?
So before I get to that, I've Googled it, and 2,500 kilograms of carbon dioxide is roughly equivalent to 6,250 miles driven.
Okay.
So it's a pretty long drive, and that's just for one SSI.
Okay. Well, I mean, that resonates with me.
So what's the future of nasal colonization and SSI risk? I think
And decolonization.
and decolonization. I think as we move away from universal screening for MRSA prior to surgery, which I think is already in the guideline position, certainly from a UK point of view, but I know quite a lot of organisations still do screen everybody for MRSA. I think naturally the question will be raised for us to answer again in the current context of whether we should replace at least some of that with some risk-based screening for Staph aureus. I do think that's a way to go, because it allows us to really focus in on the high risk patients, and to retain our decolonization approaches for patients that we know to be at higher risk. I also think that if we look at the higher risk categories where we know a Staph aureus infection in particular would be devastating, like in elective orthopedic procedures, for example, I think we need to take a really close look at the decolonization options and think about applying universal nasal decolonization. Be that mupirocin, if we really have to, nasal photodisinfection, or some of the chemical decolonization options that are coming through.
Great, thanks, John. Final comment from Catherine, which says that NHS Scotland mandate MSSA bacteremia surveillance. So that is very interesting. If you could just share your slides for me, John, and I will just conclude. So thank you, everybody, for attending, and thank you for all getting involved in the Q&A and the chat. It was a great one, actually. So loads of interaction, which is exactly what Don and I want in these sessions. A big thank you to John, marvelously presented as always, and also a big thank you to Molnlycke for partnering with IPC Partners in this journal club. We appreciate your support. In terms of what next, we've got another collaboration in our next journal club, which is the 2nd of July. We are partnering with the Infection Prevention Society, and we're looking at making infection prevention live for frontline healthcare workers. And I'm pleased to say that we've got a great panel joining John and I. We've got Professor Heather Loveday and Kerry Holden joining us for that, which is on the 2nd of July. You can see our schedule for our future journal clubs on our website. And a reminder that this session has been recorded and will be on our YouTube channel. There were some questions in the chat about whether or not this session would be recorded and where it would be available, so I've posted that link. If you'd ever like to get in touch with us, you can email us on infectionpreventionpartners@gmail.com. We're always looking for people to come on and present as guests, so we would love to hear from you if you're interested. So, John, thanks again. Thanks to Molnlycke, and we'll see you on the 2nd of July.